are the early warning signs of heart attack that people should be aware of?
A typical patient will come with chest pain or chest heaviness, burning or ghabrat.
What are the most important tests that people should consider to detect a heart attack?
To test is the lipid profile to understand the bad cholesterol and good cholesterol. Second thing is an ECG. Third thing is a stress test. And fourth thing is a 2D echo.
What calcium buildup exactly is?
Who gets this calcium? Who doesn't get this calcium? Not every person who gets a heart attack has calcium.
A rise in advanced procedures like TAVI. So who is an ideal candidate for TAVI?
Patients above 80, 90 where they got a lot of other comorbidities.
What is the first line management before reaching out to a hospital?
The one thing he has to do is lie down flat and then seek help, get an ambulance and go to the nearest hospital. The worst category, 1 or 2 family members have a heart attack, had sudden death in the family.
And live a normal life after undergoing such procedures. Hello, my name is Neha and welcome to Lilavati Hospital's official podcast series where we bring you closer to expertise, innovation and patient care that define our hospital. In today's episode, we are focusing on one of the most important aspects of our life, that is our heart. Joining us today is Dr. Anand Rao, our leading expert in cardiology, to guide us about our heart health. Before we begin, I'd love for our listeners to know about Sir. Sir, could you please briefly introduce yourself and your area of specialization?
Hi Neha, thank you. My name is Dr. Anand Rao. I'm a coronary and structural interventionist based at Lilavati Hospital, Mumbai.
To start with, what are the early warning signs of heart attack that people should be aware of?
Right. So Neha, let's begin like this. We classify these patients into various subsets. A typical patient will come with chest pain or chest heaviness, burning or ghabrat, and this comes especially on exertion, like walking uphill, taking stairs, or something unusual which is happening to that individual when he's doing a routine activity and these symptoms occur. So most importantly, a typical chest pain which is there in the front, which can radiate to the back, which can radiate to either arms. Sometimes the pain even goes to the jaws and back of the neck. So these are the typical kind of symptoms one can get, and these are the early signs of an impending heart attack, or what we call it as effort angina. Or this can lead to an unstable angina also. Second thing is, if the patient is diabetic and he got other comorbidities, the symptoms may vary. He may not get these typical pain symptoms. He may get something like breathlessness on exertion. Sometimes he gets weakness, tremendous fatigue, dizziness, and the unfortunate situation, he might have a sudden cardiac death also. So these are by and large, if you look at a broad aspect, these are the typical warning signs of an impending heart attack.
Yes, sir, that's truly important, and this can surely help us recognize the signs and for the further treatment modalities. Sir, in case if someone is experiencing these symptoms, what is the first line management before reaching out to a hospital? Well,
that's a great question. I mean, this is what we have to address the public at large. What happens? Someone develops like a heart attack at home, and that too in an odd hours. That's quite challenging. So when somebody gets this kind of symptoms, he's already got the symptoms. As I told you, these symptoms come on exertion, and when somebody has these symptoms coming on exertion, I think he needs to seek immediate help, and a humble ECG should solve these issues. But in an unfortunate situation, if somebody ignores these symptoms and it comes to a situation where he starts getting chest pain at home, I think the one thing he has to do is lie down flat and then seek help, get an ambulance and go to the nearest hospital, because at home if you have something like an aspirin or some other things you can give, but I think he has to go to the nearest hospital and seek help. So that's how I would think somebody gets a chest pain at home, they have to manage themselves like this.
Yes, sir, definitely. I think that clarity is very crucial, especially when such situation occurs. Every moment counts. Talking about calcium buildup, sir, what calcium buildup exactly is and how dangerous it can be if left untreated?
Yeah, so there's been a lot of awareness being created about calcium buildup in the coronary arteries. Coronary arteries are the arteries which are supplying to the heart, and they are on top of the heart. So there's something called as fat deposition in the coronary arteries, and this fat deposition occurs over there, which is called as atheroma, and this atheroma progresses to various complicated stages, and then a stage will come. Finally it will form a very very thick cap covering this fat atheroma, and this thick cap over a period of time gets calcified. It becomes calcified, and then there is a buildup of calcium at various levels. So the calcium buildup occurs over a period of time. So who gets this calcium? Who doesn't get this calcium? It's very difficult to answer. Not every person who gets a heart attack has calcium, or other way around too. So calcium buildup in younger individuals is not that common. So when you see a calcium score, which is predominantly done with the CT scoring system, when a young patient has got higher calcium score, that's a big concern. But calcium in the elderly is not that uncommon. It's common because it's part of the aging process, and calcium not only builds up in coronaries, it builds up in neck vessels, in the abdominal vessels, in the lower limb vessels, and so on and so forth. So the prediction of calcium, who's going to get it, who's not going to get it, is going to be difficult to answer.
Can it be reversible, or it is all about controlling?
Well, that's a great question, because when patients come to us with a calcium score, or somebody is accidentally detected to have calcium in his arteries, the first question they ask is, how do we reverse this? And most of the individuals, they blame on their diet, and most of the women who are on calcium tablets, they feel this is the cause of calcium buildup in the coronary arteries. It's not true. So calcium builds up because of various risk factors. For example, the calcium buildup is very common, as I told you earlier, in the elderly population, in patients who got chronic kidney disease. Third, in patients who are smokers. Fourth, in patients who undergone bypass surgery, now the native coronary arteries are in trouble. So these are various kind of subset. Calcium reversal is not known, but if somebody has detected calcium at an early stage, he can reverse it by doing good diet, good exercise, and monitoring or regulating his risk factors. When I say regulating risk factors, he has to get his diabetes under control, he's got to get his blood pressure under control, and most importantly, the bad cholesterol, what we call it as LDL cholesterol, that has to come down to the level which is desired. So I think diet and exercise can definitely help in the initial course of calcium buildup. But once there is established calcium, for example, if the CT angio says that the calcium buildup, the calcium score is 400, 800, 1000, these are established. To reverse this kind of calcium, it's going to be a challenge.
Yes, sir, I totally agree with sir that diet and lifestyle modification will truly help in reducing the risk of calcium deposition in the arteries and veins, as mentioned. So what are the modalities like, or the early warning signs where one can understand that he is at risk of calcium buildup?
So again, this is a great thought process, because nobody can have any symptoms pertaining to calcium buildup. So patients get symptoms when there is a plaque formation, when there is an obstruction to the arteries. This obstruction may or may not have calcium. For example, let's take a hypothetical situation. There's a 50% plaque in these arteries, and for various reasons, this atheroma or this plaque ruptures. He gets an acute heart attack. Then we do an angio, we find out there is a block, whatever it is, we put a stent and we come out. But there is no calcium in these individuals. But when you do a CT scan, CT calcium score, what we call it, CT angio, patients go for CT angio, and then the calcium score is done. Based on the calcium scoring system, if the calcium score is 400 and above, 100 to 400 is a gray zone. and 400 and above, of course, it needs an attention. Again, mind you, these scores are all calculated on the software which is there in the CT department. But as a cardiologist, I have to weigh everything. I have to take the individual's age, risk profile, comorbidities, family history and lifestyle, and then combine with the calcium score and then give a treatment. It cannot be like a mass screening. We cannot advise on an open forum like this that a mass screening has to be done and the calcium scoring has to be obtained for all the individuals. No. So this is what it is. So calcium buildup does not have any symptoms, but definitely it will be very important when it's established coronary artery disease, how to deal with this calcium. That is a very important thing.
Yes, sir, surely. Sir, what are the most important tests that people should consider to detect a heart attack?
Fine. So we are now talking about the prevention and early investigation of an individual. So let's divide this into various categories. It cannot be a general answer, because let's take a low risk category individual. Let's say low risk means he is good, his lifestyles are good, he doesn't have any family history, he is not a smoker, not obese, very active gentleman, and is leading a very, very healthy lifestyle. So these kind of individuals, probably we should start screening them maybe at the age between 30 and 40. That's when I would advise them to do probably a lipid test or a stress test or a 2D echo, something like that. Now let's take a second subset, which are moderate risk individual. For example, he's got some risk factors. Maybe he's got cholesterol abnormalities, maybe he's a little bit obese, not a smoker, but lifestyle was very hectic. These kind of individuals, I probably think at the age of 30, probably they should do their initial investigation. I'll come to the investigation later. Let's take the worst category individual. These are individuals who one or two family members have a heart attack, had sudden death in the family, they are smokers, obese, hectic lifestyles, and eating at erratic times, and all these things. So these are the individuals who I think as early as 20 years they should start getting screening. So what do I mean by screening? Screening, the main thing to test is the lipid profile to understand the bad cholesterol and good cholesterol. Second thing is an ECG. Third thing is a stress test. And fourth thing is a 2D echo. These are the four basic things one individual has to do. Second is, once you ask about this, and if he is found these things normal, but he's still not perfectly fit, then he goes for prevention in the form of having good diet, exercise, control all your risk factors, quit smoking, start eating healthy food, and most important thing in our country is the obesity. That has to be taken care, and sedentary lifestyle should be avoided.
Doctor, could you please tell us that when does a patient requires angioplasty or stenting instead of a medical management?
Great. So not every patient, as I told you, who's got a calcium score high or something like that, should undergo an angiography. And angiography is an invasive test. It has got its own side effects too. So patient who gets these symptoms, who has got these risk factors, and if you establish some sort of ischemia, I mean to say that there is some areas of the heart which are receiving less blood supply. We demonstrate that by doing a stress test. And once you do this stress test, and if the individual comes positive for a stress test, these are the individuals we take them for angiography. Once we do an angiography, there are three possible outcomes in angiography. One, he might have a minor blocks here and there, for which he can be put on medical therapy, lifestyle management, and so on and so forth. Second, the patient might have one or two significant blockages. That's the case situation. If the family is agreeing, if everybody is there, then we can put one or two stents depending on the requirement. But the third possibility after doing an angiography is multiple blockages. If there are multiple blockages, severe calcification and bifurcation blockages and more complex anatomy, these patients will definitely will be helped by undergoing a bypass surgery. So normal arteries, minor plaques, stents, and bypass surgery. Now the last, which is not that common, is diffuse disease where neither angioplasty nor a bypass would help. So this patient again have to go on aggressive medical therapy and lifestyle modifications.
So, sir, that really helps to clear our confusion about the decision making of the treatment. I'm sure our audience might have got a clarity about their decision making in terms of their treatment modalities. Moving ahead, sir, we have seen a rise in advanced procedures like TAVI. So, who is an ideal candidate for TAVI?
Okay, now moving from coronary artery disease to structural heart intervention, which is called as TAVI, that is transcatheter aortic valve implantation. Traditionally, a aortic valve, which is guarding the main chamber of the heart, left ventricle, where the whole blood is supplied to entire body, is guarded by this valve called as aortic valve. When the aortic valve opens, the heart pumps and all the blood goes, the entire circulation starts and the blood goes to the body, and the aortic valve closes, then the blood flow stops and the blood fills up in the left ventricle. So aortic valve is a very important valve, and aortic valve over a period of time gets diseased. Traditionally, it was replaced by sternotomy, that means opening the chest, opening the heart, removing the diseased valve and putting the new valve. That is called a surgical aortic valve replacement. Now, since the advancement of TAVI, which started occurring by 2005 onwards, so that valve is inserted through a small hole in the groin, like how we do angioplasty. Same way we go to the heart, to the valve, and we place the new valve which sits there and starts functioning immediately. So this is a very minimal invasive kind of thing. A typical patient is there, and then under conscious anesthesia, what we call, not even general anesthesia, is a conscious anesthesia, we do this procedure. Generally it takes about 1.5 hours, this procedure, and the patient immediately wheeled in the ICU and maybe 1 or 2 days in the hospital, and then he goes home. Now, who are the ideal candidate for TAVI? So there are various criteria for this. One is patients who are unfit for surgical valve replacements. Let's say older age group, patients above 80, 90, where they got a lot of other comorbidities. So there the TAVI is ideal to be done because surgery carries more risk than, so that TAVI can be a good option. Second is between the age of 65 to 75 and above. Now there's a rising consensus because the TAVI valves are doing so well. So more and more number of patients are now opting for TAVI, which can clearly give good results for 10 to 15 years. That's what the thing is. So once the patient understands this, if he's 70, for example, if he's 70 years old, if he wants to undergo a TAVI, he has to understand that he may require a re-procedure at the age of 80 or 85. So ideally, older age group, patients who have got a lot of comorbidities and surgical turn down are the ideal candidates for doing TAVI.
That's really fascinating, and it really shows how cardiac care has advanced in technology. So now let us talk about the recovery. Now, after the procedures like angioplasty, angiography and surgical procedures like TAVI, how fast is the recovery of the patient and how does it differ from different procedures?
Right. Let's take one at a time. So you talked about angiography. Angiography is nothing but diagnosing. It's just diagnosing. Most of the time it is done from the wrist artery over here. Typically it takes 20 minutes to 30 minutes to do an angiography. Once the angiography is done, and if nothing is to be done, generally patient goes home within 4-5 hours. In a rare situation where radial artery is not good, we do it through the groin. In that case, if it's done in the morning, by late evening the patient can go home. Now, second subset is patients who have undergone angioplasty. That means stent placement. So this patient, if it's a simple straightforward angioplasty, they stay in the ICU for 24 hours and next day they are discharged. If the angioplasty requires multiple stents, if the heart pumping is low, if the angioplasty is done in an acute situation, if the angioplasty is done in a cardiogenic shock situation, these are the patients who tend to stay longer time in the hospital. Third thing, we talked about TAVI, that is aortic valve implantation. So these are the patients who generally stay 24 hours in the ICU, then 1 or 2 days in the hospital, and on the 4th day, they tend to go home.
So to end this on a reassuring note, can patient live a normal life after undergoing such procedures?
Absolutely. So, as I told you, it all depends on what level the patient comes to us. As I told you, if somebody has got a 90% block in one of the arteries and heart pumping is normal, he's back to life within a week. Everything is normal for him within a week. If somebody comes where I've done multiple stent angioplasty, heart pumping is on a lower side, maybe the recovery takes time, but with the medications, with the modern medications, and there are several good medications to improve the pumping of the heart, generally these patients bounce back within a month, and then they are back to their work. Even the same thing with TAVI. TAVI patients, by and large, are older, elderly population. So these patients are also back in action within a week, and whatever they were doing earlier, limited activity, they can do it in a much better way and not getting any symptoms. So by and large, these are minimally invasive procedures and the recovery is quite good.
Yes, sir, that was a really very thoughtful and informative session, and we were very glad to have you here at Lilavati Hospital, as you are one of the best doctors in cardiology we have at our hospital. Thank you, sir, for joining us today here at Lilavati Hospital. We are very glad.
Thank you for having me over here. Thank you very much.